Hello everybody and welcome to our module on other antibiotics. In this video I'm going to focus on a number of antibiotics that don't really fit into any of the classes I discussed in the other videos. So in this module we'll go over quinolones, also vancomycin, metronidazole, and we'll finish with nitrofurantoin. I'll start with the quinolones, and all the quinolone antibiotics end in the word floxacin. So for example, ciprofloxacin is a quinolone antibiotic, so is levofloxacin, so is moxifloxacin, and so is norfloxacin. All quinolones have a double ring structure like I've shown on the screen here, and most of the quinolones also have a fluorine attached. For this reason, you will often hear many quinolone drugs referred to as fluoroquinolones. All of these antibiotics inhibit important enzymes for bacterial DNA synthesis. Specifically, they inhibit two enzymes that bacteria need in order to synthesize DNA appropriately, and those enzymes are called DNA gyrase and topoisomerase 4. The two enzymes that quinolones inhibit are examples of topoisomerase enzymes, and in order to understand what these enzymes do, we have to first talk about what a topoisomer is. Let's imagine that we have a circular strand of DNA inside a bacterial cell. Now let's imagine that that strand becomes knotted up such that it forms a figure 8. These two strands of DNA are identical to one another. They are isomers. However, they have different shapes. Therefore, they are called topoisomers. And it turns out that as bacterial DNA is replicated, it often forms knots like this figure 8 and even more complex structures. So enzymes have evolved called topoisomerases, which break the DNA and reconnect it so that the knots and the tension in the DNA is relieved and so that DNA replication can continue. DNA gyrase, the first enzyme that's inhibited by quinolones, is a topoisomerase that introduces double-stranded breaks into DNA and then repairs those breaks, and this undoes the knotting of DNA and relieves the tension. Topoisomerase 4 is another topoisomerase enzyme, as its name implies. Its job is to separate daughter chromosomes from one another. This is a process called decantination. So when these two enzymes are inhibited by quinolones, that leads to damage in DNA, and that leads to cell death, and therefore the quinolone antibiotics are bactericidal. Once you understand this mechanism of action, it's very easy to understand how bacteria can become resistant to quinolones. They can alter their DNA gyrase enzymes and their topoisomerase 4 enzymes so that these enzymes no longer bind to the quinolones. In addition, some bacteria have been shown to alter their cell permeability to the quinolones or to promote efflux of the drug. Quinolones are very popular antibiotics, and that's because they are generally well tolerated and they cover a wide range of bacteria. They cover many gram-positive bacteria, gram-negative bacteria, and also atypical organisms. Common clinical uses only in adults. We'll talk about why children should not be prescribed quinolones in a minute, but among adults, common clinical uses include UTIs. That's because these antibiotics generally cover E. coli and other enteric gram-negatives. They're also very popular for pneumonia because they often cover strep pneumonia and H. flu and atypical bugs that can cause pneumonia. And they're also popular for abdominal infections because they cover many enteric gram-negative bugs. Not all the quinolones have the same spectrum of activity, so let's talk about specific quinolone drugs now and which bacteria they cover. One of the first quinolones on the market was a drug called nalidixic acid. This is unique among the quinolones because it is not a fluoroquinolone. This is its structure shown on the screen here. It does not have a fluorine atom. Another early quinolone was a drug called norfloxacin, and these drugs had mostly gram-negative coverage only. They had very limited or no coverage of gram-positive bacteria, and this generally limited their utility. After those early quinolones, the quinolone structure was modified until ciprofloxacin came to market. Ciprofloxacin has the structure shown on the screen here, and it quickly became very popular, and it's still commonly used today. Ciprofloxacin has some gram-positive coverage, although it's rarely used alone to cover gram-positive organisms because of resistance. Its major advantage is that it has very good gram-negative coverage, including the bacteria Pseudomonas aeruginosa. In fact, among the quinolones, ciprofloxacin has the most reliable Pseudomonas coverage. Because of its good gram-negative coverage, it's often used for UTIs and GI infections. In addition, Cipro ear drops are often prescribed for otitis externa, which is swimmer's ear, which you may know is caused by Pseudomonas. After ciprofloxacin, the quinolone structure was modified further to create levofloxacin. Levofloxacin has more gram-positive and atypical bacteria coverage than Cipro. This makes it a very good drug for pneumonia. It has better strep pneumo coverage than Cipro. It also covers most methicillin-susceptible Staph aureus. It is, however, less effective against Pseudomonas compared with Cipro. Therefore, it's usually used to cover gram-positives and atypicals, especially in pneumonia. This is a very popular pneumonia drug. After levofloxacin, the more modern quinolones were developed. These include drugs like gadifloxacin, sparfloxacin, and moxifloxacin. These drugs are designed to provide better gram-positive and atypical coverage than levo so that they can be better drugs for pneumonia. Just like levofloxacin, however, they attain their better gram-positive and atypical coverage at the expense of coverage for Pseudomonas. They are not as effective against Pseudomonas as levofloxacin. And just like levofloxacin, these drugs are often used in pneumonia. In general, these drugs are very well tolerated, and that's why they're so popular. Common side effects include GI upset. Many patients who take quinolones develop anorexia, nausea, vomiting, and belly pain. This has been reported in up to 17% of patients. Also, mild neurologic side effects, including headache and dizziness, are sometimes reported in about 2 to 6% of patients. A very rare but feared side effect of quinolone drugs is cardiac arrest. This can occur because these drugs can potentially prolong the QT interval on the surface EKG. The QT interval is the interval from the beginning of the Q wave to the end of the T wave, and if it becomes markedly prolonged, that can lead to the arrhythmia torsade de pointes, which can lead to cardiac arrest and death. This occurs because quinolones can potentially block the potassium channels in the heart, and this can lead to torsade de pointes. Quinolones have been reported to cause tendon rupture or tendinitis. This most commonly occurs in the Achilles tendon, and it's more common among older patients and patients on steroids. The mechanism of this effect is not well understood. In addition, quinolones are not used in pregnant women or in children. That's because animal studies have shown these antibiotics to be toxic to developing cartilage. And an easy way to remember both of these side effects is to just think of quinolones as having potential musculoskeletal side effects in adults, children, and pregnant women. A final point about quinolones has to do with antacids. These are drugs that I discuss in detail in the video on GI pharmacology. Antacids can disrupt the absorption of many drugs, including quinolones. This is especially true for aluminum and magnesium hydroxide. It's also true for sucralfate, which is an ulcer drug that contains aluminum. These drugs can interfere with the absorption of many drugs. Tetracycline is a classic drug whose absorption is interfered with by antacids, but fluoroquinolones also have their absorption disrupted by antacids. Our next antibiotic is vancomycin. Vancomycin inhibits peptidoglycan formation, which is necessary for maintenance of bacterial cell walls. Specifically, it binds to peptides that need to be cross-linked for proper formation of the cell wall. It binds to peptides that include two alanine molecules linked together. The way this is usually written in textbooks is that vancomycin binds to D-alanyl D-alanine peptides. These are two alanine amino acids linked together, and the letter D is included because they're in the D configuration, in contrast to most human amino acids, which are in the L configuration. Once vancomycin binds to these peptides, it prevents cross-linking. As a result, bacteria cannot form new cell walls, so the rate of cell wall breakdown exceeds the rate of formation, and this leads to cell death. Therefore, vancomycin is bactericidal. And this is the same effect on the cell wall that beta-lactams have, however, it's via a different mechanism. Beta-lactams inhibit transpeptidase enzymes that cross-link these peptides. Vancomycin binds to the peptides and blocks the action of the transpeptidase enzyme altogether. This is easier to understand with a picture in this drawing. The blue structures here are vancomycin molecules. The alternating green structures are the NAM and NAG backbone of bacterial cell walls. Sticking out from those cell walls are peptides, and the last two amino acids on the peptide strands are alanine, shown as the red dots here. Vancomycin will bind to those alanine amino acids and prevent transpeptidase enzymes, which are the gray structure shown on the screen here, from binding the alanine amino acids and cross-linking the bacterial cell wall. Beta-lactams inhibit the transpeptidase enzymes. That has the same effect, but via a different mechanism. Once you understand this, it's very easy to understand how bacteria can potentially develop resistance to vancomycin. They modify the terminal amino acids in their peptide chains. Specifically, Staph aureus has been shown to modify the D-alanyl D-alanine peptides and change them to D-alanyl D-lactate. In other words, an alanine amino acid is swapped with a lactate molecule. As a result, vancomycin can no longer bind, and this is the mechanism by which vancomycin-resistant Staph aureus emerges. Vancomycin is only effective in gram-positive bacteria, and the reason for this is because it's an enormous molecule. I've shown you its structure on the screen. It is too large to pass the outer membrane of gram-negative bacteria and disrupt their cell wall synthesis. Vancomycin is generally given in two scenarios. One is methicillin-resistant Staph aureus or MRSA. When staph bacteria become resistant to the staph penicillins, then vancomycin is used for therapy. The other scenario is oral therapy for C. difficile pseudomembranous colitis. Vancomycin is poorly absorbed, so it's usually given IV. However, in the case of C. difficile infection, it's given orally so that it will remain in the GI tract and exert its effect on the C. difficile infection. And you'll often see vancomycin given empirically, meaning before a bacteria has been identified when MRSA is a concern. So for example, in patients who present with endocarditis due to an unknown cause, or severe pneumonia and sepsis due to an unknown bacteria, MRSA is often a concern, and in these cases vancomycin is given empirically. Vancomycin is generally well tolerated, but there are some adverse effects you should know about. The first one is nephrotoxicity. This was more common in the past. It's less common with modern preparations. The major risk is if you give vancomycin concomitantly with aminoglycosides. Aminoglycosides are a well-known cause of nephrotoxicity, and there are some data that suggest the risk is higher when you give them together with vancomycin. Another potential side effect is ototoxicity. This will present as tinnitus, vertigo, or rarely hearing loss. This has been reported in the literature, but it is rare. A classic adverse effect of vancomycin that you won't see in the modern era is called the red man syndrome. This is diffuse flushing, erythema, and itching. It often affects the upper back and neck and the face more than the lower body, and it occurs about 10 to 20 minutes after an infusion of vancomycin is initiated. This is caused by direct activation of mast cells, which leads to histamine release, and histamine is the word you want to remember for the USMLE Step 1 exam. This is an example of a pseudo-allergic drug reaction. It is not a hypersensitivity reaction, and for that reason it doesn't require sensitization, and it can occur with the first administration. Now it turns out this is an infusion-related side effect. It will not occur with a slow infusion, so for that reason hospitals have protocols for the infusion of vancomycin, and in the modern era you should never see the red man syndrome. Our next drug is metronidazole, which has the chemical structure shown on the screen. It is a prodrug. It must be reduced in order to become activated, and only anaerobic bacteria have an intracellular environment that is capable of reducing this drug. So it can go in and out of many cells in the body, but only if it finds its way into an anaerobic bacterial cell will it become active and exert its effect. In addition, once some metronidazole is reduced, that draws in more of the drug. This makes it very effective because it concentrates and becomes active inside of anaerobic bacteria. Once it's activated, the activated form generates free radicals which interact with DNA. This leads to DNA breakage and destabilization, and that leads to cell death, and therefore metronidazole is a bactericidal antibiotic. Metronidazole has good coverage of anaerobic bacteria that cause infections below the diaphragm. This is in contrast to clindamycin, which has good coverage of anaerobic bacteria that cause infections above the diaphragm. So metronidazole has good coverage of Bacteroides and Clostridium difficile. For this reason, it's often used in the setting of GI infections, including peritonitis, abdominal abscesses, and diverticulitis. It's often given together with a quinolone because the metronidazole will cover anaerobic bacteria and the quinolone will provide good coverage of gastrointestinal gram-negative bacteria. For example, the combination of ciprofloxacin and flagyl is another name for metronidazole, is often given together to treat diverticulitis and other abdominal infections. Metronidazole can also be used to treat infections caused by Helicobacter pylori and Gardnerella vaginalis. These are both facultative anaerobic bacteria, and therefore they have that favorable intracellular environment for this drug, and they are susceptible to metronidazole. So metronidazole is part of the triple therapy used to treat H. pylori, which can cause gastritis and ulcers. It's also used to treat bacterial vaginitis caused by Gardnerella vaginalis. Metronidazole can also be used to treat a number of anaerobic protozoal infections. These protozoa lack mitochondria, and therefore they have the anaerobic environment favorable to metronidazole. This includes Trichomonas vaginalis, Entamoeba histolytica, and Giardia lamblia. All of these protozoal infections are covered by metronidazole. Patients who take this drug often complain of an unpleasant metallic taste in their mouth. This is usually mild and they're able to tolerate the drug. There are also some non-specific GI and neuro side effects that can occur. These include things like abdominal discomfort and nausea, and rarely neuropathy or a headache. Patients who take metronidazole are often told to avoid alcohol while they're on the drug. The reason for this is because if they drink while they're taking metronidazole, they can potentially develop what's known as a disulfiram-like reaction. If you look at the bottom of the screen, I've shown the metabolic pathway for ethanol in the human body. I discuss this in detail in the biochemistry section. Ethanol is converted to acetaldehyde, and then there is an enzyme called aldehyde dehydrogenase that converts acetaldehyde into acetate. Disulfiram is a drug given to alcoholics that inhibits aldehyde dehydrogenase. If alcoholics who are on disulfiram decide to drink, they will not be able to metabolize acetaldehyde. Therefore, the acetaldehyde level will rise, and this will give them an uncomfortable feeling that includes symptoms of warmth, flushing, and sweating. And this usually discourages alcoholics from drinking. Metronidazole can potentially cause a similar reaction if patients drink while taking the antibiotic. What's interesting is the mechanism is unclear. There are data, including the study I've shown at the bottom of the screen, that suggests that metronidazole does not inhibit alcohol metabolism the same way as disulfiram. Nevertheless, a similar reaction to disulfiram can develop, and for this reason, patients should avoid alcohol when they're taking metronidazole. Our last antibiotic for this module is called nitrofurantoin. This is a rarely used antibiotic whose exact mechanism of action is incompletely understood. It is a bactericidal drug whose only use is in urinary tract infections. That's because it concentrates in the urine. And there are two things to know about this drug. The first is that it's often used for urinary tract infections in pregnancy. It's because it's safe in pregnancy, and other commonly used UTI drugs are contraindicated in pregnancy. Those include Bactrim and quinolones. The other thing to know about nitrofurantoin is that it can potentially precipitate hemolysis in patients who have a G6PD deficiency. And that concludes our module on other antibiotics.